Welcome to our video on paralytic ileus. Let's get started. We will cover the definition, pathophysiology, etiologies, clinical presentation, diagnosis, and management of paralytic ileus. Paralytic ileus is an impairment of peristalsis without mechanical obstruction. One contributory factor to a paralytic ileus is a stressful stimulus such as surgery, inflammation, or infection. This stressful stimulus activates the sympathetic nervous system, decreasing the peristalsis. If this triggering also leads to inflammation, for example, due to tissue trauma, it can lead to the release of nitric oxide, which relaxes the intestinal smooth muscle. This also contributes to a decrease in peristalsis. The decreased peristalsis results in bowel wall distension, edema, and loss of absorptive function. The most common cause of paralytic ileus is postoperative ileus. While some degree of ileus is expected following surgery, the motility in the gut should return to normal function within 3 to 5 days after surgery, and symptoms are usually mild. Infection and inflammatory conditions in the gut, such as peritonitis, can also lead to ileus due to the inflammation and sympathetic nervous system activation. Additionally, some medications decrease peristalsis in the gut. The most common medications associated with ileus are opioids, anticholinergics, and anesthetics. Let's read an example. A 72-year-old woman is brought to the emergency department due to severe abdominal pain. Her last bowel movement was 5 days ago. She has been recently diagnosed with unresectable pancreatic adenocarcinoma, and she was started on morphine infusion due to pain from metastatic bone disease 1 week ago. The physical exam reveals a distended abdomen with tympanic bowel sounds, but no rigidity or rebound tenderness. Abdominal X-ray reveals uniformly dilated small and large intestines filled with gas. So what is the most likely precipitating factor of this patient's current condition? This patient presents with abdominal pain and absent bowel movements for the last 5 days. She was started on morphine infusion due to pain from her metastatic pancreatic adenocarcinoma. Abdominal X-ray reveals uniformly dilated small and large intestines filled with gas. These findings together are suggestive of a paralytic ileus. The most likely precipitating factor of this patient's paralytic ileus was recent initiation of opioid analgesic. Opioids decrease gastrointestinal peristalsis by activating mu receptors and predispose patients to paralytic ileus. Paralytic ileus may present with nausea and vomiting. However, in contrast to small bowel obstruction, paralytic ileus typically presents with a constant and dull abdominal pain rather than a colicky pain. There is also associated abdominal distension. Additionally, paralytic ileus presents with decreased or absent bowel sounds on physical exam. This is also in contrast to small bowel obstruction, which typically presents with hyperactive bowel sounds. Another clinical feature of a paralytic ileus is the delayed passage of flatus following surgery. The laboratory evaluation for paralytic ileus should include a complete blood count, basic metabolic panel, liver function tests, amylase and lipase. A complete blood count should be ordered to evaluate for leukocytosis, which could indicate an infection contributing to the ileus. A basic metabolic panel should be ordered because hypokalemia can contribute to paralytic ileus, and potassium can easily be replaced if needed. Finally, liver function tests, amylase and lipase, should be ordered to evaluate for the presence of gallbladder dysfunction or postoperative pancreatitis, both of which can contribute to ileus. Liver function tests can be elevated in gallbladder dysfunction due to obstruction of bile flow and acute inflammation causing liver injury. Amylase and lipase will be elevated if pancreatitis is present. The initial imaging of choice for paralytic ileus is an abdominal radiograph. One should expect to see dilated loops of bowel with air present in the colon and rectum. Thus, we typically don't see a transition zone in paralytic ileus, in contrast to a small bowel obstruction, for example. This is an abdominal X-ray image of a patient with paralytic ileus. We can see multiple dilated loops of small bowel, with no transition point or obvious mechanical obstruction. These findings are classic for paralytic ileus. Another example, a 62-year-old woman is evaluated in the hospital for absent bowel movements and inability to pass gas for the last 4 days. 5 days ago, she underwent surgical repair of a strangulated femoral hernia. She has no abdominal pain or vomiting. Her vital signs include a blood pressure of 125/80, heart rate of 82 beats per minute, and respiratory rate of 12 breaths per minute. Abdominal X-ray reveals uniformly dilated, gas-filled, small and large intestines. So what is the difference between this patient's condition and the bowel obstruction on a plain abdominal X-ray? So let's review. This patient has absent bowel movements and an inability to pass gas for the last 4 days. This phenomenon is known as obstipation. She recently underwent surgical repair of a strangulated femoral hernia. Considering her recent surgery and the abdominal x-ray findings of uniformly dilated, gas-filled small and large intestines, this patient most likely has paralytic ileus. While we see uniformly dilated, gas-filled small and large intestines in the setting of paralytic ileus, bowel obstruction is characterized by proximal intestinal dilation and distal intestinal collapse with no gas. The management of paralytic ileus is very similar to management of small bowel obstruction. Paralytic ileus is managed conservatively, beginning with IV fluids and correction of any electrolyte abnormalities. Patients should be NPO to encourage bowel rest and may require decompression with a nasogastric tube for comfort. Patients with an ileus should also have serial abdominal assessments performed throughout their stay to monitor for any changes indicating small bowel obstruction or worsening abdominal pathology. Patients should also be taken off any medication that could cause ileus, which may be difficult in the postoperative setting with pain. If a patient has pain in the setting of an ileus, NSAIDs should be the medication of choice for analgesia since they do not cause decreased peristalsis. Let's take a look at the right side of the algorithm that corresponds to ileus. The first step to distinguish between obstruction and ileus will be an abdominal x-ray. In a patient with ileus, this will show a patent intestinal lumen with dilatation of the large and small intestines. There should be no transition point. With the supporting history and these radiographic findings, the patient can be diagnosed with an ileus and managed conservatively. So another example, a 63-year-old woman is evaluated for absent bowel movements and inability to pass gas on the 4th day after undergoing cholecystectomy for acute cholecystitis. She has a New York Heart Association Class II congestive heart failure treated with spironolactone, captopril, furosemide, and metoprolol. Laboratory findings are significant for potassium levels of 3 microequivalents per liter. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135/80, a heart rate of 91 beats per minute, and a respiratory rate of 16 breaths per minute. Abdominal x-ray reveals uniformly dilated, gas-filled small and large intestines. The patient is placed on bowel rest regimen after intestinal decompression with nasogastric tube. So what is the best next step in the management? So the patient complains of absent bowel movements and inability to pass gas on the 4th day after undergoing cholecystectomy for acute cholecystitis. Abdominal x-ray reveals uniformly dilated, gas-filled small and large intestines. These findings are consistent with the diagnosis of ileus. Her laboratory findings are significant for potassium levels of 3 microequivalents per liter, consistent with hypokalemia. Electrolyte abnormalities such as hypokalemia often precipitate ileus. The next step in management would be to correct hypokalemia, which is likely the cause of ileus, and that concludes this section.